a few high-yield principles tie the entire algorithm together. First, the MCV classifies the type of anemia, but does not establish its presence. That requires the hemoglobin. Second, ferritin is the first test in microcytic anemia because it is the most efficient way to confirm or exclude iron deficiency, the dominant cause. Third, reticulocytes differentiate red cell production from destruction, which is the mechanistic question that organizes the entire normocytic branch. Fourth, aplastic anemia is characterized by low reticulocytes because the marrow is failing, not responding. And fifth, macrocytic anemia must always be split into megaloblastic versus non-megaloblastic because the underlying biology, treatment, and prognosis are entirely different. Now, having covered the full algorithm, we turn to one of the most clinically important and commonly tested distinctions in hematology: differentiating iron deficiency anemia from anemia of chronic disease. These two conditions can look superficially similar. Both can be microcytic or normocytic, and both show low serum iron, but they have completely opposite treatments. Giving iron to a patient with pure anemia of chronic disease is unhelpful and may even feed pathogens or worsen oxidative stress, while missing iron deficiency in a patient with inflammation means leaving a treatable anemia uncorrected. To understand why the diagnostic tests work the way they do, you have to anchor the discussion in hepcidin, the master regulator of iron homeostasis. Hepcidin is a 25-amino acid peptide produced by hepatocytes that binds ferroportin, the only known cellular iron exporter, on the basolateral surface of duodenal enterocytes and on macrophages of the reticuloendothelial system. When hepcidin binds ferroportin, it triggers ferroportin's internalization and degradation, effectively shutting the door on iron leaving the cell. The result is twofold: dietary iron absorption from the gut drops, and recycled iron from senescent red cells gets locked inside macrophages instead of being released back to transferrin for delivery to the marrow. In iron deficiency anemia, hepcidin is suppressed because the body is desperately trying to maximize iron uptake. Ferroportin stays on the cell surface, dietary absorption is maximized, and any stored iron is released. But stores are empty, so the marrow still goes wanting. In anemia of chronic disease, the inflammatory cytokine interleukin-6, along with interleukin-1, tumor necrosis factor alpha, and others, drives hepcidin synthesis through STAT3 signaling in hepatocytes. Hepcidin rises, ferroportin is destroyed, and iron gets sequestered inside macrophages, even though total body iron is normal or even increased. This is sometimes called functional iron deficiency. The iron exists, but the marrow just cannot access it.